thank you all very much for coming, and a particular thanks to Mark, to Laura, and to Ricky for this invitation. It's an incredible privilege for me to be here, to be back here in Leeds. I never was actually in this room before. My old days, it was down the road in the old medical school down there. Wonderful place. Before I tell you a little bit about my topic, I do want to say a little bit about this extraordinary man who's pictured on the left and in whose honour this lecture is being held. Charles Thackrah, who is very much, or was very much, a Leeds man, born here. I actually, John, I have to correct you, I was not born in Leeds. For my sins, I was actually born in Lancashire, which, for those of you from Yorkshire, will realise that I will never, ever be forgiven for that. Charles was born here in Leeds in 1795. He trained as a doctor, even though his parents really wanted him to join the church, to become a vicar. And he began his practice in medicine at the very tender age of 20, when most of us are actually just starting out. But he was already practicing at that age. And he developed an extraordinary interest in occupational health. And in fact, that really became his profession. And having researched and observed the conditions of people at work in many places, particularly in Yorkshire, he produced a work which really became the first and the most, in a sense, set the precedent for everything that followed in occupational health. A book which went into several editions, which he wrote, entitled "The Effects of Arts, Trades and Professions on Health and Longevity." And that was back in 1831, so quite some time ago. Around that same time, he accepted an invitation from one of his colleagues to create a medical school, what became the Leeds Medical School, and he actually moved his anatomy school to be part of that medical school when it was first founded, and took a very active role in the teaching from the very first months of that medical school in 1831. Very sadly, he died only a few years later, in 1833, from tuberculosis, which he'd been living with for several years. He was only aged 38 when he died, and yet he'd managed to do all of that in that short career. He's buried, in fact, in Dewsbury, in a churchyard there, and his epitaph apparently reads, I've not seen it myself, but it reads, "After a life spent in the active practice of that profession of which he was a distinguished ornament, he fell a martyr to his exertions." I personally benefited from his work, you've heard, I trained here in the medical school. It's perhaps something of a coincidence that I also then worked in Dewsbury, and the very first two patients I saw when I went into the medical ward in Dewsbury, my first day at work, both had tuberculosis. Problem still then. Particular honour for me to be back here today to be giving this lecture on the 40th anniversary of the Nuffield, as John has described it. I owe it a huge amount, a great debt, because it was here in 1993-94, 25 years ago, isn't that terrible, quarter of a century before I guess some of you possibly were even born, that I did a Masters in Public Health here. And that set me on the course that John has described with the World Health Organization. Though at the time that I was here, it wasn't called the Nuffield Centre for Health and Development, it was called the Nuffield Institute for Health in those days, and it was in a separate building up the road. So I'm one of those sort of 5,000 alumni of the Nuffield who've been involved in the work here for some time. And I've had the pleasure when I was at headquarters of receiving every year a group of students, master's students, coming from the Nuffield to get an orientation on global health in WHO and in several of the other organizations in Geneva. And it was always an incredible privilege to spend some time with the students. Not just because, and I don't know if any of you are in this, part of those same batches, but the skills, the interest, the enthusiasm that they brought was obvious. But what was most interesting for me was the extraordinary diversity of experience and, of course, of geography that they brought, which was quite different, I must say, to many other groups of students that we had coming to Geneva. I would say that the groups coming from the Nuffield were by far and away the most diverse that we had, and it was a delight always to spend time with them. It's always, for me, a great pleasure and a privilege to be able to invest in the lives of young people earlier on in their careers, and that's largely what I'll be focusing on today. And I do hope that WHL will continue to provide a warm welcome in years to come to your students, because this truly is an outstanding institution of research and training and expertise. My title that you've seen up is Impacting on Global Health, Changing Skills and Changing Values. But on further reflection, I'd like to actually propose a little bit of a change to that title. I think a better title would be Remember the People. And I'll try and explain why, and I hope you'll begin to understand when I try to answer two questions today. I'm going to ask two questions, try and answer them. What has changed over the last 40 years in global health, and what does not change? But what I must emphasize right from the start is that I am neither a historian, nor am I a researcher, and so therefore what you hear you must take with a pinch of salt, I would suggest, but you must also be free to challenge me, and I hope there might be a bit of time at the end for a few questions. And I'm quite likely to say I agree, because what I'm presenting to you is a very personal perspective on these two questions. My aim is not really to educate or to train. My aim is really to inspire those of you who are considering particularly a career in global health. And I'm going to start, therefore, by telling you a little bit about my career. John's very correctly summarised it, but I'd just like to give a little bit more information about it. What was I doing 79 years ago this summer? Well, I was that person there on the right. I was in a remote hospital up in the north of India, a little mission hospital called Herbertpur. I was doing my medical elective as a fourth-year student here at the medical school. I had a fabulous experience. I was doing outpatients, inpatients, helping with surgery. I had some tremendous mentors there, particularly a Japanese-American surgeon by the name of Sato, who sadly died last year. And it was through that experience, that formative experience on my elective, that I learned two things. The first thing is I was not cut out to be a surgeon, despite this picture. It's a very long and a very profoundly embarrassing story of why I discovered that, and it involves mistaking bowel and bladder, which is not a good thing to do when you're holding the scalpel, but fortunately the patient did recover. And second thing I discovered, more importantly, is that I wanted a career in community health. And I spent some time in that mission hospital. I also spent some time in a much larger mission hospital in Ludhiana, in the Punjab, where I was based in a small community centre I think it was probably about 40 miles outside of the city of Ludhiana. It's a place called Narangwal. And it was there that I first saw the way that community health can make such a difference. It was a system that was based on community health volunteers who was supported, there's a few female community health volunteers on the left, supported by a team, professional team coming out of the centre and doing public health in the community with the local people. And this map is a map of the village, this village, where they were working. And that experience demonstrated to me the critical importance of information and knowledge. Not just information and knowledge on disease, but information and knowledge about the community. And this was a map which shows the infrastructure, schools, you might not be able to see it very clearly, but school, clinic, post office, and so on. But it also shows where the most vulnerable groups in that community are. And if you look down to the, I'm going to try and find a way of making this work. There we go. Does that work? Yeah. Look, a little bit of a dot there. That circle is what they call the TB zone, because there are 4 patients with TB living in that area. And around it, you may just be able to see a few houses with an M next to it, which means there was a child who was malnourished. And what you can see immediately, straight away, is clearly that part of the town, or the village rather, is the disadvantaged area, compared with up further to the upper part of the village there, where you've got the more of the facilities, post office, some of the political offices were up there as well. Clearly there is an area in the village which is more disadvantaged than others, and it was realising the importance of data that really helped me. So following my completing my studies here, I did house jobs in Wakefield and Dewsbury, and did senior house jobs here in Leeds at in the LGI and then at Jimmy's. My wife and I then went out to Nepal in 1984. We worked for 16 years there. The first few years we were out in a tiny little hospital. It's actually right down here. We used to live up there on the hilltop there. We worked there for a few years, but very quickly got involved in the community health program, which supported a population of about 25,000 in that area, focusing initially on maternal and child health, growth monitoring, immunisation, etc. But we also had a series of programs which were designed to improve water and sanitation over there, and non-formal education, community health volunteer training, and so on literacy here. And it demonstrated to me straight away that though health care is important, in fact most of the benefits for health come from areas like education, like water and sanitation. It was a profoundly important experience for us, and we had a fabulous time there. But after a few years, the government asked us to get involved in doing tuberculosis control in the whole of that district, which extended right up to the border with Tibet. And so I moved with my wife, we moved to the district centre. We worked in the district health office, and we were supporting the government district health infrastructure in delivering TB control in the district. We also did a number of surveys for TB in the whole of that area. Fascinating time. It was about a week's walk north into a very remote part of the district, where we'd do tuberculin surveys and household surveys for TB. You can't go and just do that, though, when it's a population which has got no access to any other health services. So we would, of course, provide primary care, simple diagnosis and treatment. So this is me doing a little clinic in the outside with a group from one of the villages there. Had a fabulous time, one of my greatest memories. A few years later, actually just after finishing my master's here, we went back to Nepal, and I'd expected to go back to that Thackrah town, but we ended up in Kathmandu supporting the national program. As John said a little bit more about it, I won't say much more, just to say that, again, that was probably one of the most fulfilling periods of my life. And those of you who are thinking about a career in global health, do think of working at the country level. It really is just an extraordinary experience. You have that wonderful, so it's the crossover between immediate fulfillment in terms of seeing things change with individuals and scope of breadth of influence. It sort of crosses over at the national level. And it was a wonderful experience there. We did roll out the DOTS strategy across the country in three or 4 years, worked with an extraordinary director of the TB program, a man by the name of Dirga Singh Bam, who a man of tremendous commitment, enthusiasm, energy. We used to say bomb by name and bomb by nature. Remarkable man. Then, at the end of that time, back at the start of the new millennium, we moved to Geneva, and I started working in World Health Organization. I joined WHO whilst I was in Nepal, and worked again in TB, and had a wonderful time, as John has said, establishing this drug facility which provided fixed dose combination drugs to countries around the world, reduced the costs of treatment to around $10 per course of treatment. In just over it was literally over a few months, prices fell that rapidly once we'd come up with high quality fixed dose combination products, and still very involved in that program. The drug facility is still very involved in TB control globally. And then after 2 or 3 years doing that, I was the director of our TB program, the person actually who you just see on the left there in the picture. Dr. John Lee was elected as the Director General. and he asked me to go with him to his office as an advisor, which I did. And then later, when he sadly died in 2006, Dr. Margaret Chan was elected as the Director General, when she asked me to stay on and eventually to become her Chief of Staff, the Executive Director position. So I did that from 2000. I was effectively in that office from 2003 to end of 2017, and as John said, then came back to Yorkshire, best place in the universe. So that's how I have changed over the last 40 years. What I'm now going to do is try and tell you a little bit about how the world has changed in terms of global health over the last 40 years. Because that's certainly far more important than how I have changed. So let's go back to 1979. All right? 1979 was really quite an extraordinary year in many ways. It was the year that Russia invaded Afghanistan and Iran became an Islamic state, which had a personal impact on me, both of those events, as I travelled out to India through Afghanistan and back to the UK through Iran on my elective, and had obviously some flight difficulties and challenges, as you can imagine, as both of those events were occurring at that time. China introduced the one-child policy in that year. The Sony Walkman, for those of you who remember it, was invented in that year, launched, and the snowboard was first invented in that year. So important things happening. Those of you who have a musical pedigree in progressive rock, it was the year that Pink Floyd released The Wall. Great album. It was the year that Margaret Thatcher was elected as Prime Minister. It was 3 years after the Director General then of WHO, Dr. Halfdan Mahler from Denmark, had first proposed the concept of health for all. 2 years since the last case of smallpox, and it was the year after the profoundly important Alma Ata conference that I'm sure you've all heard of on primary health care. It really was a time of great optimism in public health, in global health at that time. And certainly it was a very optimistic World Health Assembly that met in May 1979. The President of the US at that time was Jimmy Carter, and his wife Rosalind came to the Health Assembly as a campaigner for mental health. And in fact, the two of them then came back 25 years later in 2004 to speak at the Assembly. After Mahler had just been re-elected as the Director General a year before, and he presented to the Assembly his report on the outcome of the Alma Ata meeting, and he also presented a paper which was formulating strategies for achieving health for all by the year 2000. And his address to the Assembly, he's an extraordinary speaker, an extraordinary man. His address to the Assembly was characteristically upbeat, and it began with a very bold statement. The great reforms in the history of mankind started with social philosophies that in turn led to social action. I'm convinced that the attainment of an acceptable level of health for all will be no exception. We have the philosophy, we have initiated the action, we must now make sure that this action is accelerated in keeping with that philosophy. And his focus was very much on people as the centre of their own development. And again, in characteristically almost preaching words, he also said the following: people are the key to their own salvation, and it is part of our action to help them save their own health. Let's jump forward then 40 years to the present day and to the World Health Assembly that's just taken place in Geneva this last month in May. And the Director General, the new Director General, Dr. Tedros, he elected 2 years ago. I worked for him for 6 months, again as his Chief of Staff. He addressed the Assembly last month. And there were clear echoes in his speech of what had been said 40 years earlier about primary health care. These were his words. Primary health care is where the battle for human health is won and lost. Strong primary health care is the front line in defending the right to health, including sexual and reproductive health rights. It is through strong primary health care that our countries can prevent, detect and treat NCDs. It's through strong primary health care that outbreaks can be detected and stopped before they become epidemics. And it's through strong primary health care that we can protect children and fight the global surge in vaccine-preventable diseases such as measles. But there's a subtle difference between what he said this time and what was said 40 years ago. For primary health care is now a means to an end, universal health coverage. And as Dr. Thackrah said, there'll be no universal health coverage without primary health care. Health for all has effectively become now universal health coverage. And he concluded himself with a phrase that was coined by his predecessor, Dr. Margaret Chan, which itself echoes that of Dr. Marler: remember the people. I'm going to come back to that again later. So, what's changed in global health over the last 40 years between those two speeches? I'd like to highlight changes in 8 areas. Conceptual changes, epidemiological, demographic, economic, technological, governance, strategic and political. But don't worry, I'm not going to spend hours on each of those, because each of those is worthy of a lecture in its own right, obviously. And again, I want to make a little bit of a disclaimer. Each of these topics is worthy, as I said, of a lecture in its own right. So it's bound to be superficial. Secondly, I know that there are people in the audience who know much more about these individual topics, much more than me. So again, I stand ready to be corrected. I'm not trying to provide a history of global health. I'm not trying to sort of say these are the events that happened. I'm trying to really just say, let's look and try and get an understanding of what has changed and what therefore that means for us in the future. So, I'm going to start with this concept of global health. Because 40 years ago, we never used the term global health. We were much more likely to use the term international health, which is a term that's got a long history, probably used for the last, since the 19th century, and usually used in 2 main ways. The first one is the concept of health work abroad, usually in relation to working in developing countries, usually in relationship to issues like communicable diseases, maternal child health, water and sanitation, etc. And then a second meaning, which was largely in relationship to cross-border issues, the inter part of international. And one great example of that is the international health regulations, which describe the responsibilities that countries have for disease outbreaks, particularly those that have a risk of crossing borders. The second term that began to be used in the middle of the last century, of the 20th century, was that of world health, and obviously largely in relationship to the World Health Organization. It really, though, is much more of a way of describing health on a worldwide scale, and it's usually used in conjunction with another noun, like World Health Day, or World Health Report, or World Health Organization, to describe something that has significance to all countries everywhere. And it's largely, I say, usually used in relationship to WHO, but there is actually a World Health Summit, which takes place in Germany each year. It's nothing to do with WHO, but largely it's usually used for things related to the World Health Organization. Third term that came up, again, primarily I would say around the 1970s, was this concept of community health, which I've mentioned earlier. Had been used for quite a lot previous to that, but it really had its place in the sun in the 70s and so on. It really describes the health status of a defined group, a community of people, and the actions and conditions that relate to their health. Often used in the context of community health program, and usually talking about where a program is owned and managed and run by the local community, though not exclusively. It was very much promoted by the World Council of Churches Commission, the Christian Medical Commission of the World Council of Churches, and they were very influential in the 1970s, particularly in terms of presenting their work to WHO. And it was that presentation and that partnership with CMC that in fact was formative in the development of primary healthcare as a concept in the early 70s. Still hear it, but not quite as much. And then we get to global health, which really is a 90s phrase that has stuck with us and is largely how people talk about public health on the widest possible stage, and has been defined, and I'm using a definition that was produced by Jeff Copeland and colleagues a few years ago, defined as the area of study, research and practice that places a priority on improving health and achieving equity in health for all people worldwide. It's an important consideration. It's no longer focusing on the poor, it's all people everywhere. Interestingly, I'm using that definition simply because it was one of the first. There is still no real agreement on what we mean by global health, but we use that term all the time. And the latest iteration is planetary health, which I'm sure you've all been you've been using and hearing, and a very recent concept, which again I'm sure many of you know, arose out of, I think just 2015, just 4 years ago, arose out of a partnership between the Lancet and the Rockefeller Foundation. And a very simple and helpful definition: the health of human civilization and the state of the natural systems on which it depends. I believe it was Richard Horton, the editor of the Lancet himself, who came up with that definition. The Lancet, by the way, obviously thinks there is a difference between public health, global health and planetary health, as it has 3 titles, separate titles, one for each area. I suspect that for most of us the distinction is not a very significant one, and in fact I think that probably most people in many developing countries certainly would either use these terms interchangeably or wouldn't in fact use any of them at all, and they just talk about health generally. We're the ones in the West who have decided we want to break everything up into all of these different areas. Sorry, let me just go back a bit. Why have I particularly highlighted this then? I mean, it may be nice conceptual, but why have I decided that that's where I'm going to start in looking at what's changed? It's because words matter. The way we talk about things, in some respects, helps us to understand what we think about them. Words matter. It's why, therefore, I've used the term conceptual shifts rather than just shifts in terminology, because they help to show us how we have changed the way we think about health over these 40 years. And in ways that I think are incredibly positive. In thinking about health globally, we're thinking about the health of all people, we're not just charity-based groups going out to help the poor. We truly think about the world as an interdependent community of people with whom we all have an increasingly intimate relationship through technology, and therefore with whom we also have a shared identity and responsibility. So I think the term global health does have merit in focusing on equity and the whole world. I think planetary health also has merit in helping us to think through what it means for the health of this nation, or these nations, when people's health is improving. We are more healthy, we are more prosperous, we are more at peace than we have ever been before in human history. And yet, the world is sicker than it has ever been before in human history. And it's because of human history that it's in that state. So I think these two issues, the equity issue and the planetary systems issue, are important for us and are useful in helping us to think through what we mean by health. But I will go on very quickly to look at the changes in epidemiology. And all I'm going to do is show you that slide and say, as we all know, there have been profound shifts in epidemiology, in the burden of diseases over the last 40 years. I won't do so now because it will take too much time, but I was going to show you the website that this slide is taken from, which is the website of the Institute for Health Metrics and Evaluation, based in Seattle, healthdata.org. Please do go there. It is an extraordinary repository of very useful data and visualizations which help to communicate health and disease and death and disability, and all that is changing and has changed over the years in these areas. But of course, as we all know, the major shift that we've seen is this move from communicable diseases towards non-communicable diseases, such that non-communicable diseases clearly make up the greatest burden of disease globally, including in developing countries. So I won't go into that in any more detail. Many of you here know far more about it anyway than I do. Just let's take it as a given. And I'm also going to take this a little bit as a given, the shifts in financing and economic shifts in global health, which have again been profound. Two quick graphs, one showing how health expenditures are increasing globally, consistently. This is a graph from 1995. I don't have anything going back to 79, but it would show, I'm sure, a very similar trend downwards. What I would like to point out, and don't ask me about the sudden jump in 2013, I can't explain that, but what it does show you, if I was to ask you where does development assistance for health fit onto that graph, it's the green line, it's the green part of the column. And you say, where is the green part of the column? Well, it's actually sitting right on top of the, is that dark blue or is that violet at the top there? I'm no good on colours, my a bit of colour blindness, but there is, I can assure you, a tiny little green little bit on top. That represents the development assistance contribution to health expenditures globally. Minuscule. Health expenditures are driven by domestic and not just government, but private and also personal expenditures on health consistently, and have been and will continue to be so. But we will have a quick look at development assistance. There's the graph of development assistance for health over the same period, 1990 to the present day. And as you can see there, that's broken down by the different areas into which funding has gone. It shows you that there's not been actually a massive difference in terms of which diseases get what, or rather the difference between what is broadly allocated to health in general and what is assigned to specific diseases. What it does show you, though, perhaps a little worrying for some, is that the profound increase in development assistance for health that we saw from the early 2000s seems to now have plateaued. And of course, as health expenditures continue to rise, it means inevitably that the proportion of influence that development assistance will have is declining. But again, we won't go into that in any more detail. You can find out more about it yourselves. Three issues I'd like to raise very quickly on demographics. First of all, aging, profound shift there. Now, the elderly in society now exceed in proportion the young in society in terms of under fives. And in fact, overtook round about now. We're at that cusp where the elderly are now make up a greater proportion than the young, aged under 5. Secondly, urban and rural, which we all again recognise. We're past that, long past that. The urban populations now exceed rural populations. But here's one that you might not be aware of. Some of you will be, I'm sure, but here's one you might not be aware of. And a very interesting statistic. 88% of the next billion entrants into the middle class will be in Asia. 88%. That's over the next 5 to 7 years. There's about 170 million people every year now entering the middle class. In other words, those who drive the economy in most countries. The middle class make up the majority of people in most countries. 88% will be in Asia. What's that going to have in terms of an impact in countries where, as with many middle classes, there are increased expectations, but also increased demands not to raise taxes? And as the Brookings Institution said in their report, which actually presented this data, governments may find themselves unable to meet the growing expectations for middle class, enhancing programs such as universal health care, public education, pensions and affordable housing without resorting to deeply unpopular tax increases. Technological shifts. I am not the person to speak about this. I'll just highlight those 3 areas that have been important. Awareness of new risk factors. What's the most significant airborne disease that we now face? It's air pollution. 9 million people dying as a consequence of air pollution every year. Development of new technologies is the area that everybody's very interested in looking at. And there's a few to highlight, of course: the microbiome, genomics, and of course big data, artificial intelligence, and so on. Again, you could spend hours and hours and hours talking about all of these, all relatively new, all potentially having a profound impact on health. And linked to that a shift really through these technologies in our focus as we move really away from population-based interventions, or the interventions will still be population-based, but they'll be driven by individual person data that will define what specific intervention they need. Some are calling it precision public health. That perhaps is not quite the right term. It might be better to use something like predictive public health. But clearly, data is going to change the way that people receive their public health as well as their curative health in the future. Not all of these technologies are uniformly beneficial. We're also seeing, you have to say, for example, the growth in antibiotics is also leading, and access to antibiotics, also leading to antimicrobial resistance. The threats that certain uses of new information technologies to health are clear. The fact that food companies are now going direct to kids through Facebook, through YouTube, through numerous other avenues to directly market subliminally in many respects to kids is frightening. And particularly because parents don't see the same streams that their kids see on their own individual sites. So there's a lot to be worried about as well as to be thankful for. Strategy shifts, I think I'll race through this because in the interest of time, but there have been quite significant shifts in the way that we have looked at health from the whole shift we mentioned earlier from primary healthcare through to what was called GOBI-FFF, selective primary healthcare. Again, those of you who looked into this in the past will understand how that shift has led to a fragmentation in health, which has had consequences in many ways. That shift away from a sort of a uniform, comprehensive approach to health to single programs, programmatic approaches, led to this fragmentation, which has had a profound impact on programs in countries, each program developing its own system of treatment, diagnosis, prevention, systems of supervision, training, monitoring, etc. Often in health systems that are fragile anyway. And in fact, that led to this concept of proposing that financing for health should no longer be through vertical programs, but was described diagonal. Never really understood what that meant. You could give money diagonally rather than vertically. But the aim was to try and strengthen health systems as well as put money into vertical programs. I think that's still an argument that remains to be won, as it were. And then finally, from the MDGs to the Sustainable Development Goals. Of course, all shifts. I'm going to talk about that more, but I think let's move on. Shifts in governance, again, this fragmentation led to shifts in governance at the global level. Multiple programs and partnerships, many of whom were established at the beginning of the millennium, causing a great competition for funds, causing a distortion of priorities, causing a policy incoherence. National level just as important. Competing priorities leading to fragmentation in delivery, higher transaction costs, and a brain drain often from the government-trained government employees into these new programs. So not necessarily that increase in development assistance for health did have some negative consequences. Nobody would argue that it wasn't needed, but it certainly wasn't uniformly beneficial. Political shifts in global health moving, as it were, down from a simple technical issue. The WHO Constitution defines the Director General as the technical and administrative head of the organisation, interestingly, to an economic issue through the wonderful World Development Report of 1993 on investing in health. And certainly health was very well recognised as a development issue in the MDGs in the year 2000. Health then became a security issue, health on the agenda of the Security Council for HIV in 2000 and then Ebola in 2014. Various health security initiatives launched. Each president of the US needs to have their own, so we have two, one called the initiative and one called the agenda, one under Bush and the other under Obama. And then health as a political issue, by that meaning at the highest level of politics, at the head of state level. Health at the G8, been there since 1996, some tremendous achievements, particularly in 2000 through the Okinawa Conference. Health at the G20 over the last couple of years. Health and foreign policy at the UN, and a whole series of summits and high-level special sessions at the United Nations on health over the last few years, particularly HIV, NCDs. Most recently then we've had antimicrobial resistance, 2016, tuberculosis last year, and this year it's the year of universal health coverage. So tremendous political agenda developing around health. Where will it go? We don't know. But what do these general shifts imply for global health? That's what we really want to come back to. That's not all that's changed. What does it mean for us? Two things. First of all, it means we need to look at the competencies that we will need in order to really continue to make a difference in global health. That's particularly important here in a medical school in the Nuffield, as you are involved so heavily in, and so importantly, in training young people for the future. So what does it mean for us here? I've jumped ahead in through my notes, so just give me 1 second while I come back to them. I think first of all it means that we need to rethink what our core competencies are in global health. I, and some of those of you who were also training 40 years ago and after that, our core competencies in public health in those days were things like epi and stats and the determinants of health, economics and program management. Those were largely the core, and they remain at the core, the heart of public health teaching. Let's not lose that. But what we've seen is the growing importance of a new set of core competencies, of much greater awareness, political awareness, and experience and skills in policy development, as we've shifted from programs to policies as being the major drivers of health, of the ability to manage complexity, which I was never taught, and yet I have seen, particularly through my experience in WHO, as being incredibly important, of understanding data, not just what the data is, but how you can use it in many different ways, and particularly, of course, Internet of Things, big data, artificial intelligence, robotics, having such an impact on our lives will increasingly be important in public health. An area, though, I think we have perhaps put on, we've always said it's important, but we've never really given it the attention it needs, and that's this whole area of interpersonal skills. If public health is going to be driven by people who are good at working together, then we need to look at how we work together. We need to be looking at collaboration and mentoring and partnering, negotiation skills, communication, particularly now social media with the vaccine hesitancy agenda and things like that, capacity building and mentoring. We've always recognized them, but we've perhaps not quite given them quite the same clarity that perhaps we've needed to. And then, of course, at the end of that, if we're going to be working intersectorally, we need to be able to speak intersectorally. There's a whole area of intersectoral literacy that we need to develop, which again I think has potentially been rather neglected over the years. And I have the privilege not just of being able to be here, but also working with a university, the University of Hong Kong, in helping them develop a new undergraduate program on global health and development. One of the first things we did was to develop a literacy in health and development for students on that course. The first students will be starting this year. And I think that that is going to be the way forward in many universities and institutions, looking at the broadest possible education at the beginning. Don't wait until students get to the master's level before doing health and development. Get them off to the start, right at the beginning. I think that's going to be increasingly important. I may be wrong, but I think that's probably where many of us are going. What does not change in global health? And this is my last session, last part of the talk. First of all, I think it's going to be values that don't change. And let me explain what I mean by that. Values are ideals and aspirations that we regard as being important in molding and influencing our character, our attitudes, and our behavior. They're different to ethics. Ethics are really as it were, the rules of behavior. So if you're going to sort of characterize the difference between them, you would capture values in some form of a sort of a creed, whereas your ethics will be a rule book, a code. They're different. Why are they so important, though, for global health? Because the challenges that we face in implementing these rapidly changing technologies and so on present all sorts of ethical issues, to us, and we need to be able to implement them safely, ethically, and equitably. And if we don't have a core set of agreed values on which we're making those decisions, then we will be making the wrong decisions. Rising costs, particularly of aging populations, rising costs of healthcare and aging populations, are demanding questions of governments around how they raise money and how they spend it, in ways that, if they don't come from a value base, are going to be purely economic and not therefore necessarily in the interests of all. We've got to really look at the role of big data. Again, this is not my area of expertise, but all I hear is both amazingly encouraging and at the same time deeply worrying around how big data can have an influence on our health. And if we're not looking at that from a values-based judgment, then we could again be making wrong decisions. The growing politicization and privatization of health is all part of this. But I think most importantly, the real reason I think values are so important is because it helps us keep a human face on public health. It helps us look at it from a humanitarian perspective. And I'll rush through this very, very quickly. I was going to go through each of these four major documents, the WHO Constitution, the Alma Ata Declaration, the Millennium Development Goals, and the Agenda for Sustainable Development, and look at how, in each of those four critically important documents on health, values and principles are set out. And some of them are quite remarkable. I'm just going to look at one, the WHO Constitution from 1946, which starts out by saying that the principles that follow on human rights, non-discrimination, etc., are basic for happiness, harmony, and security. Isn't that remarkable? That the WHO Constitution, first and foremost, puts happiness, harmony, and human security as its primary aim. I think that's wonderful. It's a fabulous document to read, but I won't do it. But I'm going to very quickly, and again, I'd love to spend a lot more time on this. This is an area that I think we really need to invest in. The whole issue of what are our values in global health? How do we then inculcate them in health professionals? And how do we measure them? Which again is a very difficult question. But I'm going to come up with three rather. Values that influence the way we view the world, values that influence the way we conduct our work, and values that influence the way we behave towards one another. I won't actually go through them in turn. I can make these slides available to you later, but there basically is a whole series of issues or values that I think are fundamental to those three things. How we view the world, how we conduct our work, and how we behave towards one another. And you can summarize them, those three areas, with 6 words. A focus on sustainability and social justice, a focus on integrity and invention, and a focus on humanity and harmony. I like alliteration, as you can see, but it helps us remember them. Forget this, I'm not going to go through that. I'm going to finish with this slide, because this person is my former boss, Dr. Margaret Chan. She exemplified for me the importance of values in global health. She finished her very last address to the Assembly in 2 years ago, 2016, with these words. Above all, remember the people. Behind every number is a person who defines our common humanity and deserves our compassion. We remember people as being those whom we serve, but we also remember people in several other ways. We remember those who have gone before us, on whose shoulders we sort of metaphorically stand, and I would include in that Charles Thackrah, who we remember today and whose honour we meet. We remember those who've trained us, who've mentored us, who have helped us become who we are. And again, I just simply want to reiterate my profound thanks to this school, Leeds Medical School, and the Nuffield for what they invested in me and enabled me to do what I've been able to do over the last 40 years. And finally, those who've encouraged and nurtured us. And those are usually our family and our friends. And of course, I so want to thank my great parents. My dad is very sick at this moment in time. My amazing wife and my 2 dear kids, one of whom is here this evening, this afternoon rather, who are often my greatest critics, but they tell me they always do so in love. And I'd like to conclude really with that word love. Because if you wanted to summarize the values that I showed earlier with one word, I think that word would have to be love. Love for the world in which we live and the people we serve. Love for the work that we do, we're passionate about, that we enjoy, and love for the people that we're working with. I think if we were able to make that the ultimate value of all that we do in global health, I think that would be truly transformational. Thank you very much.